Hi, constipation in the elderly. Constipation in the elderly is common and tends to increase with age. The possibility of disease, such as colon cancer, increases with age and therefore requires a sense of urgency in evaluating older patients. If the patient is confined to bed, fecal impaction must always be considered. Constipation is associated with Parkinson's disease, diabetes, intestinal obstruction, irritable bowel syndrome, diverticulosis, and low levels of potassium. Diverticula are small pouches that bulge outward through the colon or large intestine. If you have these pouches, you have a condition called diverticulosis. Irritable bowel syndrome is a disorder that affects the large intestine. Signs and symptoms include cramping, abdominal pain, bloating, gas, and diarrhea or constipation, or both. Irritable bowel syndrome is a chronic condition that will need to be managed long term. Diabetes can damage the nerves controlling the digestive tract, which can lead to constipation. An intestinal obstruction occurs when your small or large intestine is blocked and passage of food cannot occur, and food and gases begin to build up. The muscular weakness that occurs with low potassium levels can manifest in many ways, such as constipation, difficulty breathing, abdominal distension, or exercise intolerance. Constipation in children. Constipation in children is usually related to diet. When it occurs, it can be caused by organic causes or psychological causes. The inappropriate passage of normal stool may indicate a psychological component. Constipation, the difficult or delayed passing of stools associated with soiling, may indicate an organic cause. In infants, constipation may be caused by a disease called Hirschsprung's disease. This is also called megacolon, which, if diagnosed, will require surgery to correct. An anal fissure may also be a cause of constipation in infants. Colon cancer. Colon cancer is the commonest cause of intestinal malignancy. The mortality rate is high and is seen mostly in the elderly, particularly elderly men. Symptoms usually present with blood in the stool, recent changes in bowel habits, feces leakage when passing gas, difficulty in defecation because the mass is interfering with the passage of feces, abdominal discomfort, symptoms of anemia. The physician will want to do a colonoscopy. Surgical excision is the treatment. Screening can also be done. High sensitivity occult blood tests. Both polyps and colorectal cancers can bleed, and these tests check for tiny amounts of blood in the stool that cannot be seen visually. Blood in the stool may indicate the presence of conditions that are not cancer, such as hemorrhoids. So not all blood in the stool is cancer. A stool DNA test can also be used. The only stool DNA test approved by the Federal Drug Administration to date is Cologuard. It is a multi-target test that detects tiny amounts of blood in the stool, as well as 9 DNA biomarkers and 3 genes that have been found in colorectal cancer and precancerous advanced adenomas. The standard test is colonoscopy. In this test, the rectum and entire colon are examined using a colonoscope, a flexible lighted tube with a lens for viewing and a tool for removing tissue. Idiopathic constipation. Idiopathic constipation, as mentioned in video number 1, there is usually no structural or systemic illness found. Idiopathic constipation can be related to diet or the slow transit of food through the GI tract, the gastrointestinal tract, or irritable bowel syndrome. Again, irritable bowel syndrome is a disorder that affects the large intestine. Signs and symptoms include cramping, abdominal pain, bloating, gas, and diarrhea or constipation, or both. Irritable bowel syndrome is a chronic condition. The bulk of patients have constipation caused by poor diet. They should develop better eating habits. Eat a diet high in vegetables, cereals, fruits, and grains. One indication that enough bulk has been eaten in the diet is seen when stools begin to float instead of sink. The patient should take plenty of fluids. The patient should develop the habit of responding to a need to defecate as soon as possible, instead of putting it off. The patient should avoid laxatives and opiates. If the dietary modifications do not produce results, then the patient can add fiber in the form of Metamucil, etc., into the diet. The physician's objective will be to rule out organic causes of disease and to educate the patient about normal bowel function. Well, I hope this helps. Have a good day.